Good morning. So thank you so much, Brigida, and thank you to the CCF organizers for the invitation to speak today. It's really an honor to be here, and thank you to the families as well for joining us. So today I'm going to give a brief talk on the update and challenges in cell-based therapies in leukemia, and just an outline of what we'll go through. So childhood acute lymphoblastic leukemia, and primarily talking about B-cell ALL, is the most common childhood cancer. 25% or 1 in 4 children that are diagnosed with cancer have acute lymphoblastic leukemia. And as you can see to the right, the outcomes for this disease are actually quite good. We're at a point where around 90% of children will be cured. However, what about those that aren't cured or those who relapse? Unfortunately, for patients who relapse, less than 50% will survive, and with each relapse, this becomes worse. And the curative options after relapse are really challenging, in part because of the cumulative toxicities that these patients experience, and so novel treatments are needed. There are a number of different ways that we can approach relapse therapy: novel chemotherapies, antigen-targeted therapies, targeted agents using small molecule inhibitors, and then adoptive cellular therapy, notably CAR T cells, which is what I work on and what I will be talking about today. Chimeric antigen receptor T cell therapy. So T cells are a type of white blood cell that in the body are normally there to help find and detect invaders like infections. However, cancer cells like leukemia are usually able to evade our body's T cells. And so CAR T cells are genetically modified T cells that are engineered to express a receptor that's able to recognize markers or antigens on the cancer cell surface. So as an example to the right, CD19 is an antigen or target marker that is expressed on most B-cell leukemias in pediatric patients. And so a chimeric antigen receptor CAR T cell has a receptor that is able to recognize that CD19 on the leukemia cells and hopefully find those cells and kill them. So as you can see to the left, the way this works is that a child undergoes what's called apheresis, where their T cells are taken from their body. They're sent to the lab where they are transduced to have that CAR receptor expressed on the surface of their T cells. Then those T cells are expanded, and then after some preparative chemotherapy, they are given back to the child to go after their leukemia. And this strategy has been quite successful. So in 2018, the first FDA-approved CAR T-cell product, tisagenlecleucel, or Kymriah, was approved for children and young adults with relapsed and refractory B-cell ALL. And as you can see here, over 80% of patients achieved a complete response or a complete remission following this therapy. However, what was seen is that at about a year post-therapy, half of the patients, 50%, relapsed. Real-world data, meaning looking at how this CAR T-cell product performed following FDA approval across the globe, demonstrated similar findings, where 85% of patients achieved a remission after CAR T-cells. However, at a year post-therapy, 50% relapsed. And importantly, nearly half of those patients, 41%, when they relapsed, their ALL cells no longer had that CD19 marker on the cell surface. So let's talk about what relapse might look like after CAR T cells targeting CD19. There's 3 main phenotypes or 3 main appearances. First, it can be CD19 positive, meaning that CD19 marker is still expressed on the cell surface. Second, though, is something called antigen escape, where the leukemia has learned to no longer express that CD19 marker on the cell surface. And then finally, and this is rare, but an interest of mine, and we'll talk more about it later, lineage switch, where the B-cell leukemia actually no longer looks like a B-cell leukemia, but it looks completely different, and most commonly an acute myeloid leukemia. We've found that the outcomes for each of these relapse phenotypes differs. Starting out, having a CD19 positive relapse, patients tend to do better. However, over time, patients with CD19 positive and negative relapse start to have a similar outcome, whereas you can see here, outcomes for lineage switch are quite dismal. And how we approach treatment for each of these phenotypes is going to differ. If someone still has CD19 expressed on the surface of their B-cell leukemia, then we might be able to use a CD19 targeted CAR T-cell again. But we might want to think about, is there something else on the cell that we can target? Whereas for CD19 negative, we can no longer use a CD19 targeted option. And so we have to think about other options. Lineage switch treatment is still very much something that we're trying to figure out, and we'll talk about it just a few slides. So there are numerous strategies to help prevent and address post-CAR T-cell relapse, notably in CD19 positive and CD19 negative disease. And each of these strategies would take at least an hour to talk about. So today I'm going to focus in on some strategies that we've been working on in our group at the NCI. But I do want to point out that Dr. O'Corin will be talking about risk stratification to help identify high risks for relapse after CAR T-cells in just a little while. So in our group, back in 2014, we set out to explore whether we could use CAR T-cells to target a different antigen on BALL cell surface. So CD22 is another very common antigen expressed on B-cell leukemias. And so this construct, a CD22 CAR T-cell, was used actually from 2014 through 2024. And we've recently been analyzing how our experience was over those 10 years. And it was quite remarkable. We found that almost 70% of patients were able to achieve a remission after receiving this CAR T-cell product. And it was effective in patients in whom they had lost CD19 expression or failed receipt of a prior CD19 targeted therapy. However, we did see that the median relapse-free survival was only 6 months. And then notably, this construct did introduce a new toxicity that hadn't been noted very much in the past. And this is called IECHS, or immune effector cell hemophagocytosis-like syndrome. This is a hyperinflammatory syndrome that can occur following CAR T-cells, similar to HLH for those who are familiar. And so after our positive experience in targeting a different antigen, we started working on, could we target more than one antigen? You know, if we think about leukemia treatments over the years, we know that you can't just use one chemotherapy. You have to target the leukemia from multiple angles and use chemotherapy that works in different ways. And so why would immunotherapy be any different? Should we be targeting things from multiple angles? So our first foray into this was a bivalent CD19-22 CAR T-cell construct. And our initial data was published by Dr. Haneen Shalabi, a work that was in part funded by CCF, so thank you. And the initial results showed a complete response rate of 60%. However, what we learned with this construct was that it was not persistent. So while it could get patients into remission, the CAR T-cells didn't stick around to continue to keep the leukemia from coming back. And we also found that it was only really working through that CD19 and not through the CD22. So going from the bedside back to the bench with our collaborators in the lab, we came up with a new construct, the bicistronic CD19-22 construct. And I'm very excited to share with you that we have now treated 10 patients on this trial who have all achieved a complete remission following infusion. So more to come on this, but exciting to see that our multi-antigen targeting approaches do seem to be working. So we've talked a little bit about some strategies we've been working on to address post-CAR T-cell relapse or help prevent it. But what about this issue of lineage switch? So lineage switch refers to the immunophenotypic transformation of an acute leukemia from one immunophenotype or lineage categorization to another based on the loss of specific markers and acquisition of new lineage markers. But importantly, there is retention of baseline cytogenetic or molecular signatures. So in other words, there is still clonal relatedness of the leukemia to the original disease, as opposed to this being a new leukemia. And so this cartoon here shows an example. And in this example, you can see that the BALL at the beginning has something called a KMT2A rearrangement, which is a cytogenetic abnormality that is most commonly found in infants and actually decades ago was found to be associated with lineage switch prior to the use of immune-targeted therapies. However, what's been seen over the last several years with the increased use of immune-targeted therapies is that lineage switch is occurring following immune-targeted therapy in KMT2A rearranged leukemias, but also in other leukemias. And so this is just an example of what it can look like, where the BALL markers are initially present after therapy and a remission. The relapse shows a change where the 19 and 22 we've talked about are no longer highly expressed, and there is acquisition of CD33, 117, and 64, which are myelomonocytic markers, making the cell look like it's AML. But there's still retention of that KMT2A, so we know that it was related to the original leukemia. So I want to tell you a little bit about our efforts to learn more about this. Project Evolve Evaluation of Lineage Switch, an international initiative. So we treated the patient that is pictured here, Caleb, several years ago with our bivalent 1922 CAR. And unfortunately, Caleb had a lineage switch from BALL to AML, and despite a month of really aggressively trying to treat the AML, he died from his disease. And as a tribute to his legacy, we wanted to learn more about this phenomenon to try and understand, the incidence and how people are treating this to improve upon outcomes. And this turned into a global collaboration beyond what we could have expected. So we reached out through consortia to centers across the globe and ultimately ended up with 92 case submissions of lineage switch occurring after immune-targeted therapy from 3 continents and 8 countries. And of these cases, 75 met our definitions of lineage switch. The primary analysis was on the 70 cases of BALL that transformed into an acute myeloid leukemia or a mixed phenotypic leukemia or acute leukemia of ambiguous lineage. And then there were 5 that were more rare phenotypes. The majority of these cases, once we looked at them, did have that KMT2A rearrangement, or about 2/3 of them, but as you can see to the right, there were a number of other cytogenetic and molecular aberrations that were associated with the cases, suggesting that there may be other cytogenetic drivers of lineage switch. What we found was that most cases of lineage switch occurred after CAR T cells or blinatumomab, which is another CD19 targeted therapy, and that it occurred quite quickly at a median of 1.5 months after the most recent targeted therapy. When we looked at how people were treating lineage switch, we found a lot of variability. As you can see in the pie graph to the left, upper left, most patients did receive an AML-based induction aggressive chemotherapy. However, there were a lot of different things that were tried. And about 1/3 did have a response. However, it was brief. So overall outcomes matched what had been seen before, which were quite dismal, with a median overall survival of only 4.8 months. And there were, out of the 70 patients, only 8 survivors. So what did we learn? So as I mentioned, the majority of these cases were in patients that had KMT2A rearrangements. However, there do seem to be non-KMT2A cases as well, and they're not just in infants. I'll tell you that we had patients up to the age 70 that experienced this. And it occurred mostly following CD19 targeting, but was seen after other immune-targeted treatments as well. What's the best treatment approach? We still really don't know from this analysis. And the other thing that we learned is that this condition, this disease, is really hard to define, and our current definitions may not be adequate. And the mechanisms for why this happens are still quite unclear, and there may be more than one path to get to lineage switch. So this initial effort has really led to numerous future directions. And these are all very much being led by Dr. Nurali Shah. But one is a reinduction trial for newly diagnosed post-immunotherapy lineage switch with collaborators Sunil Riker and Yang Ding through the TACO Consortium. And then we're working on creating a prospective registry to continue to collect these cases so that we can continue to learn from patients that experience this phenomenon. And then finally, there is a group of biologists, hematopathologists, and experts with interest really across the country and globe working together to better define lineage switch. So in conclusion, I hope that I've demonstrated that the field of cell therapy has really made incredible strides in pediatric BALL. But post-CAR T-cell relapse remains a large challenge, and so ongoing efforts aiming to improve upon these outcomes is really critical. And not all relapses are equal, and so multiple solutions are going to be necessary. And with that, I would like to give a big thank you to my group in the hematologic malignancies section in the POB, and especially Nurali Shah, and of course collaborators and our inspiring patients and families that really help drive everything we do. Not sure if there's time for questions.
Wow, that was a really great talk, and I haven't thought a whole lot about some of the leukemia issues for a really long time, being a sarcomaologist, but back in the day when I was a student, this is now going back about 40 years, there was this challenge in that some kids with ALL did have myeloid markers. And so this is sort of nothing new in a way. It's been known for a really long time, and this is pre-genetic. So we didn't know about the MLL gene. We didn't know about any of the translocations that we found. And one of the things that I was thinking about as you talk about this is whether or not you're able to find any of these cells, even at diagnosis, because they're probably there. My suspicion is that these aren't some big transcriptional program because they have the same underlying genetics, but that there's some sort of evolution that you've basically knocked off all the easy ones with the CD19 therapies and you're left with these hard ones. Is there any thought about trying to look carefully at these patients back when they were diagnosed, at what was happening, and maybe they need to be induced with like a cycle or two of Ara-C or some myeloid-based regimen? Has that ever entered into the thought pattern?
It's a really good question. So we tried to look back at the immunophenotype at diagnosis in all of these cases, at least the ones where we were able to obtain the flow reports, but they were just that, flow reports. So it's someone's interpretation from the beginning. And we looked at it with a group of hematopathologists, and we did see that there was a lot of co-expression of myeloid markers at diagnosis. And so I think your thought about, I'm not sure. I think this is a really, lineage plasticity is at play here. There's, we talk about BALL and AML, but there may be kind of more of a spectrum than we realize. And that's where kind of how we define this comes in. I didn't have time to talk about it. We also defined a subpopulation called lineage drift, where there were changes that didn't warrant a reclassification entirely. They also had similarly poor outcomes. So I think there's still a lot to be worked out there. But I think your idea, a lot of these cases, it may be that there is a subclone that just persists with the ALL-based therapies. But I'm not sure that's the only mechanism at play. Thank you.